So hello everyone. I Yashwardhan Singh, Assistant Professor at St. Xavier's College, Jaipur, and Vice President, Rajasthan Economic Association, welcomes you to the second webinar as a part of the webinar series dealing with the issues around COVID-19. It is jointly organized by the Niti Aayog Chair, University of Rajasthan, and the Indian Econometric Society in collaboration with the Rajasthan Economic Association. The topic for today's discussion is the impact on COVID-19 on the healthcare and the education in India. And we have a panel of eminent speakers who will share their views and will be introduced before they speak. We all know that COVID-19 has affected the healthcare sector severely, both in terms of infrastructure and preparedness. Especially now when we have witnessing the reverse migration to rural India, we may find it is difficult for the health infrastructure to cope up with the increasing number of cases. Similarly, the education sector, which was brought under the lockdown initially, and in all probability will be the last one where the lockdown will be lifted, there has been a significant outflow of students for higher education nationally and internationally. But this might change for the coming few years, and therefore, we need to assess how ready we are to absorb the increase in the student enrollment locally. Thus, it becomes really important to talk about the health and education sectors and the roadmap for these sectors so that India can manage this crisis effectively. I'm going to begin by inviting Professor Vijay Singh, who is a professor of economics at the Department of Economics and Director Niti Aayog Chair, University of Rajasthan, and is currently the Dean, Faculty of Social Sciences there. He is an acknowledged expert on public policy and sectoral issues of Indian economy, and has worked extensively in the area of higher education, political economy, competition regulation, and rural development. I request him to begin the discussion by giving a background to the issue and highlight the topics of this webinar. Over to you, sir.
Good afternoon. First of all, I welcome all the three eminent panelists who have been invited on behalf of Niti Aayog Chair, TRI, TIES, and REA. Today's discussion is specifically on health and education, and the reason being that if you look at the Prime Minister's last speech to the nation, when he talks of Atmanirbhar Bharat, then he talks of pillars, 5 pillars, and one pillar of them is the demographics. Obviously, when we are saying demographics, that we are the young country, and the demographic dividend can be achieved only when we are in a good health and we provide quality education, and that is the background for this panel discussion. So, but if we look at both the sectors in context of India, there are certain major issues, because if you want to deal with any pandemic, the best thing is that you should have a strong health system. And COVID-19 has shown not only to us, to various countries, that health system is not in a good shape. That's why countries are struggling to stop the transformation or reduce the transformation and transmission, and reducing or controlling the mortality and morbidity. I will not say that India has not achieved much in health and education, but in health sectors, we have improved lots of health indicators, but still we are struggling with the ill health system of the country. Whether we look at preventive health system, or we look at routine health care, or you look at the health care involving hospitalization, or you look at the health resources, healthcare personnel, which are certain issues we are struggling with. Obviously, the experts will be highlighting all these issues, and then you see some paradoxes within the healthcare system. You are seeing the healthcare, Supreme Court says that under Article 21, healthcare is the fundamental right, but things are not right with this sector. healthcare infrastructure is inadequate. It's very clear, particularly after COVID, because if you visualize even 1% people fall sick due to corona, how much infrastructure will be required? Thank God that this virus has not spread in rural area where the majority population lives. One strong pillar of the health system we feel in a country like India is the primary health centers. But at the PSC level, the situation is very bad where 90% treatment should be, at the basic level should be given. So I can say that we have invested in health, but did not care much for the primary health centers. That's a question because one PSC is covering almost more than 5,000 patient households. Second case, now people are raising issues that we are worried about corona with a death rate of almost 3%. But if you look at the infant mortality rate in India, the child dying before completing their first birthday, this is more than 3%. In certain states, very high. So it is higher than corona. So should not be focusing on these indicators also. That is a question before us. It's not that we are trying that our manpower should be increasing, infrastructure in the healthcare should be increasing, but still we are far away. Second paradox we say, that is we are one of the cheapest healthcare system in the world, but still it is not affordable to the people. We say we are the one of the cheapest, but is not affordable by the people. And that is the reason when you look at the India out of pocket expenditure in health is very high, almost 60% plus. So that is again a contrast. Another area we see, we say that we do not have human resource in healthcare sector, less than 1,000 doctors, one doctor for 1,000 patients, but still India is famous for medical tourism. That is again a contrast. And because health is a state subject, so we see wide interstate diversity, interstate variation in case of healthcare infrastructure and healthcare outcomes. So how we are going to check that? Because if you look at the EAG state, there is a North Indian states which are highly populated, and we find the health system comparatively poor in comparison of other states. Another area we come to, there is the pharmaceuticals. When you see that we say that India is one of the famous hub for pharmaceutical industry, or which is one of the pillar for affordable healthcare. But as we study in economics, comparative cost advantage in international trade, this cost advantage had pushed us that we should be importing raw material from China because it is cheaper in comparison of India. So question is that when we are dependent for raw material or intermediaries of a pharma sector on other country, how long we can go in the direction of self-reliance? Similarly, the equally important is the medical equipment. When we saw the PPE kits and other things, we said that we are not producing, we are importing these kits. Now, when we are talking of self-reliance, do we think that we should be thinking in terms of localization of pharmaceutical industry and medical equipment industry? Then when we are talking of localization, should be focusing on the state specific. The state should also have some manufacturing units of these pharmaceutical and medical equipment. Another area we come to this healthcare financing. One thing is very clear that healthcare financing, as far as the public expenditure on health, the public allocation on health is concerned, we are debating for a long time that it should be at least 3%, but still the public expenditure on health is around 1% of GDP. If you see overall of GDP, including everything, it comes around 3.6% total expenditure. So one area is That is, whether allocation is important, that you can be allocating, government can be allocated for 3% of GDP also, but how we are implementing, that is equally important issue. And this is common for education and health both. Both sectors, we are arguing that both sectors should attract more allocation from the government, but we see complete shift that people are shifting from public to private system, both in case of health and education. So that again raises a question whether the allocation is sufficient and how we are implementing, that is equally important. Second case the people argue is that we invested more on tertiary education, tertiary health in case of prevention or primary health care system, that is to be, or you can say that is people pushed or business people pushed, that we should be investing more in hospitals because we allowed equal participation of private hospitals also. Another case is that if you look at the funding, Professor Gupta must be focusing much on this. If you look at the funding within the public expenditure, the majority of funding is state specific, or states are allocating those funds. So how states are going to allocate higher funds, particularly in EAG states, the North Indian states, these are the states already struggling for certain revenues. Now, in a present case, I can say there has to be a coordination between private hospitals and public hospitals, and private hospitals should be certainly coming forward to control this pandemic. But one thing is very clear, in the long run, we need to strengthen the public health system, that is medical colleges, hospitals, primary health centers. Otherwise, we cannot think of universal healthcare and controlling the situation in times of pandemic. One thing I think which we say, that is the medical tourism or high-end hospitals. Now, even rich people must be realizing that COVID has forced us to think that we have to safeguard the poor people also, because if poor person is getting this disease, that can lead to us also. So that is, my society might be thinking that poor people are equally important in case of healthcare. Or once we are out of this corona lockdown or corona 4, 5, 6 months, will India demand measures to promote health for all? That is the last question I will be raising for the healthcare. Now we come to second important area, that is higher education. One thing I'm listening for the long time, that when you come to higher education, that higher education system is in crisis. This I heard for the first time when I joined as assistant professor in University of Rajasthan and then gone for orientation course. And in inaugural address, still I remember we were told that higher education system in India is in crisis. And after almost 30 years, again we are repeating the same thing, that higher education system is in crisis. And one thing we are criticized throughout is that quality of instruction in the classroom is far from satisfactory, or we can say it is the poor classroom teaching. Again, we come to this case, that is spending on education is again depending state to state and depending on the financing of the state government. And major thing we have to think in time of corona, when we are discussing various options, that majority of students in higher education are enrolled in government colleges, government funded colleges and state universities. We might be thinking of various measures, but we have to realize that majority of students are enrolled in colleges, in universities, in state universities, which are not in good shape, or I will not say they are as advanced that the measures we are suggesting. because after Corona, we have locked down all the university and colleges. After lockdown, you see a different line coming in a crisis that we should be going for online teaching, online examination, online evaluation. I also get one or two call that should be come for presentation for online examination, online evaluation. But here I want to raise certain questions looking at the background of large number of students. Do we have that type, or does the student have that type of infrastructure with them that they can cope up with this online teaching, or the institution has infrastructure that they can cope up with this online examination or online evaluation system? Because online evaluation is going to cost to the universities which are already struggling for funding. So question I am raising for higher education is regarding this Corona thing only. Given the digital gap in India, how successful will the digital education model be in the country like ours? Similarly, will India be able to embrace learning anywhere every time? Will the underprivileged lag further behind? People who do not have resources for online teaching, or will it lead to the innovation in the field of education, or will it lead to the agile infrastructure setup and fall flat? So today I want to listen from Professor Abhiru Mukhopadhyay that looking at the COVID situation and looking at the higher education system in the country, particularly for masses, how we are going to cope up if Corona continues or situation like Corona comes. In case of emergency, how can we deal with that? With that, I will stop here. Thank you very much.
Thank you, sir. Now we'll be moving on to our next speaker. We have Dr. Ashok Pangaria, who is a renowned neurologist and professor emeritus neurology at SMS Medical College. He was the former vice chancellor of Rajasthan University of Health Sciences, Jaipur, and a former member of the planning board of the government of Rajasthan, a recipient of Dr. B.C. Roy Award, the highest Indian award in the medical category, and he was awarded the 4th highest Indian Civilian Award of Padma Shri by the government of India in 2014. We would like to hear from you, sir, on the challenges to the health sector. Over to you, sir.
Yeah, good evening. Thanks, Dr. Yashovardhan Singh, Dr. Vijayveer Singh, my esteemed colleagues who are going to talk after me, the brilliant people in the audience. It is, of course, very interesting and exciting to be part of a seminar which deals with health, economy, and education. After Dr. Vijayveer Singh talked about the health delivery systems in India, I think my focus, what I get from your invitation was that more relevant to the corona, the present situation, and what we have learned from managing this menace at the international level and at the national level. World across, this is the story of biology and economy, which normally should go hand in hand. But India, having been rising up as economy power, we are the part of the BRIC nations. We stand with a 2.5 trillion economy, 4th or 5th internationally, but that perhaps paradoxically we cannot say of the health delivery systems in India. Despite the economic growth, which should normally produce a robust health system in a country, that has unfortunately not happened in India. And what Dr. Vijayveer Singh talked about, the different indices in India, we still are far behind the rest of the world, and even in some of the situations worse than Bangladesh and Sri Lanka. But I think that is a long way and it needs a discussion because almost 60, 70 years we have been changing the names of our means the policies and planning. It started with health for all, universal health for all, the Millennium Development Goals, the extended Millennium Development Goals, and now of course the Ayushman Bharat. But still the things have not, of course, some degree of difference you can obviously see, but 70 years is too long a period. Still our people have to spend 70% out of their pocket expenses. And the total GDP allocation to health sector is much less vis-a-vis the Western countries. It's 1.9 vis-a-vis 10% or more than that in developed countries like US or Europe. And of course, we have a system which is different than what happens outside. But today's talk would more be oriented towards Corona. That is what in fact I thought. If of course there are a lot of questions could be asked on different issues, but I think my focus would be more relevant to the health delivery systems, our successes and our failures in last 3 months that we need to analyze, because ultimately we need to be prepared for future. And that is one of the reasons for all the conferences we are holding across the nation, that what can we do now or what we would do in future. This is true that such a thing has happened after 100 years, after the 1918 Spanish flu, which killed almost 5 to 10 million people, or 50 lakh to 100 lakh people all across the world. And of course, the things have very significantly changed with so much development in science, technology, medicine, and we are converging. We are a part of converging technology where each science actually contributes for the development of human being. But I think it's a lesson for the human beings also, because whether this coronavirus was man-made or it was animal transfer, ultimately the Homo sapiens are responsible for it. Philosophically, if you talk, I think it is a war by nature against human arrogance and excesses. When we talk of corona, the management and the medical issues, at this moment, we have crossed China in the numbers, and it is almost 85,000 people. So there is a silver lining that the death rate or the mortality rate is a little less than the rest of the countries, which of course we should be giving credit to our people. But before we go further, I think the audience should be aware of some of the basics on corona, or the disease which affects or afflicts the human beings. It is a triangle of balance: the agent, host, and environment. If there is a balance in the three, the individual remains healthy, that he has sufficient immunity, the virus or the bacteria is not there, and the environment is favorable, you feel secure. But what happens is when the immunity is decreased, or when the virus is virulent, or it's a new form of virus which the body has not experienced, or the human body has not experienced, then is the kind of pandemic which we are looking at, they actually spread in. So what happens is that this virus had huge invasiveness and infectivity. It could infect very rapidly. 3 means the reproductive rate is 3. One could infect the 3 others. And how it infects is very interesting. And that actually should be a lesson for us after the lockdown as well. Because this spread, which occurs across, is related to coughing and sneezing. So partly in the air, partly the droplets fall on the ground and the fomites get infected, and you actually get infected from them. It is interesting to note, I think, that a sneeze and a cough, the sneeze produces 3,000 droplets which run 200 miles per hour, and a cough from an infected individual or an asymptomatic carrier would result into 50 miles per hour, 3,000 droplets with 200 million viral particles. Can you just imagine that? A sneeze or a cough, that is the reason why you need to protect yourself, and that is the reason why we are in the lockdown. But what happens is, do you know this, that you need just 1,000 particles out of those 200 million to get infected. So obviously the role of the mask, the hand washing, the distancing is so important. But remember that if you're sitting across a man who is an asymptomatic carrier and or a patient or who suffers with coronavirus, if he's taking breath, it is only 20 viral particles per minute he is throwing. So if he sits with you and he doesn't talk to you, then he actually takes half an hour to 50 minutes to infect you. If you do it 20 into 50, you make it 1,000. But if you're covered with your face, you're conversing, because when you converse, actually the virus becomes double in the strength, in the sense that it sends more than 40 particles instead of 20. So sitting at a distance, the interpretation is that if you sit for long in a gathering, you are more likely to be infected. That is the reason why individuals have infected people around in the churches, in the schools, or in the large gatherings, or in the marriage or larger functions. And that is the reason why government actually banned large gatherings by 144 initially, and later on by locking us down, or it was a self-arrest, you can say. So actually short-timed exposure for picking up a bread or picking up vegetable, or a short interaction, well protected of course, will give you sufficient protection if you stay for a short while. So when we go ahead, when we talk of India, the first case in fact arrived in India on 30th January. From 30th January, actually, unfortunately, our policymakers and the health experts took it very lightly, I would say. Actually, there is a criticism of WHO and other agencies. In fact, for 2 months, because we started actually screening our passengers across at the airports only on 28th of February, which is almost 2 months. We did not prepare for our medical workforce or common man for testing, or for mask, or for sanitization. So what happened is, even at that stage, we used only the thermal scanners. So those people who are asymptomatic carriers, they who don't have fever, you will be surprised to know that almost 40% to 50% are asymptomatic carriers, and milder cases actually can escape thermal scanners. And Indian people are sometimes wise, even though it is actually a hierarchy for themselves, because they take crossing and cross the airports. So actually we allowed large number of people with asymptomatic carriers into the society, which led to the spread. So had we actually prepared ourselves with PPE, with masks, with tests, we gave a very little significance to larger number of tests or accumulating mask PPEs and all. One of the super spreaders, you would be surprised, is the hospital itself and the medical professional himself. At larger places across the world, I was actually reading an article which shows very interesting data that world across, actually, these were the hospitals which produced the spread, what we generally call as nosocomial or hospital-acquired infections. So you should be very careful in visiting hospitals. And obviously, we need to create a system where actually you don't mix COVID and non-COVID patients. Because in a single hospital, if you talk like SMS, every day there are 60,000 people, they enter hospital for their treatment. So if they mix up with some of these COVID, actually the spread would be rampant. So it is the hospital, the nursing staff, and that is the reason why you need adequate amount of PPE kits and protect your medical professionals or the nursing staff or those people involved in taking care of human beings, whether it is police or the Safai Karamcharis or the essential services and all that. So actually what we should have done, that when China was struggling from December to February, we should have studied their model of success and failures and actually should have put that into practice. So by 22nd March, we started to know that the disease is increasing, and on 25th, since 25th, we are in lockdown, and hopefully there would be some changes by tomorrow, which is the 17th of May. So the question is that, how do you take care of the slowdown? Because the fact is that, as Dr. Vijay Veer Singh says, that it is a complete disruption of the unorganized labor and, of course, the economy. The virus has not given shock to just the human life, but it has also significantly affected the livelihood. And that is the reason world across, people are talking of a balance between life and livelihood. What do we do? Actually, one, of course, is that you should be very clear that the high-risk people beyond age of 60 and comorbidities of diabetes, hypertension, bronchial asthma, coronary artery disease, stroke, all these people have to escape from the virus till the time the drug is available or you have a vaccine which can protect you. The question is that why India was a little outlier in terms of the number of deaths and the number of cases. Of course, one of the factors could be the lockdown, but lockdown is simply not a panacea, since actually where there was no lockdown, the comparison being either Sweden or even Pakistan or Bangladesh, who carried it later on, or the Sri Lanka. And then, of course, they had the Vietnamese people, the Koreans and all, they had different kind of models, and they have been, of course, been the successful models. So what we do is take care of your elderly population with comorbidities. And what else you can do is that you have to test it extensively, because you have now produced three kind of places. One is the red zone, the orange zone, and the green zone. The green zone, of course, the collector can take a call and open it significantly, but the large gatherings need to be prevented. Or the large gathering, I told you, would predispose you to the exposure of a single or multiple sneeze or cough, and it is certainly not permitted. And I'm sure the government will not let the functions or the large gathering happen. Not, of course, the schools. You can actually take into the online situations, like we are also considering online consultations, and we generally try and give consultation telephonically in the beginning, those who have follow up with us, but largely actually till the time a clear solution or a drug is available or a vaccine. Of course, there's huge optimism on the side of the vaccine because there are 106 laboratories working, and as far as the Oxford, the Israeli, and the United States, they actually intend to probably release it by October, because the human trials are already on, and those people who have discovered, and India, the Serum Institute, also is very optimistic about it. So uh, part of that, then what do you do is you actually the only in the orange part where the number of cases is less than 10, 15, one can try and open the economy. The red zone, of course, the institutions and all, everything remains to be closed. And you need to open a short term, as I told you, that moving out and taking a bread, all the vegetable, all the essential things, which probably we are already doing, and short exposure things of essential items with a relatively lesser exposure. So if the exposure instead of 1:3 is 1:1, we would get into what we call as herd immunity. So some degree of exposure, which is not as much as we say that the single virus can infect 3, but the exposure to 1:1, according to Bailey's theory of immunity, can bring out some kind of systemic immunity across the society, which we call as herd immunity. It is understood that almost 60 to 70% of people need to be immune or develop immunity. And Germany, if you have read, they have started giving the immunity certificate. So even when actually we should be planning more tests to undertake the antibody titer in the human beings, so as to know the degree of immunity, and that would allow us to move freely. The other question is that your medical workforce needs to be protected extensively. You need quality personal protective equipment, because it is not the number which you can produce. It is the quality of the equipment which will save the human being, which will save the medical professional, and in turn would save the human life, because not only he takes care of the human life, but he is a potential super spreader or a spreader himself. So that, of course, is very, very important. The other thing for all of us is that, remember, mask gives you double protection. If two people are wearing mask across, both of them are protecting each other, and this is well known. There should be no confusion. And of course, the government has also now given clear instructions that those who don't wear mask outside would be fined. So hand washing, masking, and all those things would, and a lot of other things would actually be online. What is there to learn for the medical education and the medical professional systems? As Dr. Vijay Singh rightly points out, that it is the villages so far not infected. It is highly probable that the Indians are outliers because of some kind of immunity. For the purpose of general knowledge, let me tell you that immunity is of 3 kinds. The genetic immunity, which you have a system which actually protects against the yeah, if you want me to close, the lessons learned are that you need a clear, good surveillance team. you need preventive strategies, you need sanitation, you need increased number of critical care experts, both the paramedics and the doctors. You need people with infectious diseases, the field centers, the specialized COVID centers, the mobile services, and the ample availability of tests. We know, to conclude, with a remark that COVID has been no extraordinary shock. It has affected the human being and the livelihood. And actually, it is the need of the time that both the shocks are taken care of for the future of the nation and for the future of the human beings. Thanks for inviting me here. Thank you very much.
Thank you, sir. Thank you for your valuable insights. Now we'll move on to our next speaker, Professor Indrani Gupta. She is the professor in Health Policy Research Unit at the Institute of Economic Growth, Delhi, which is known for its policy-oriented research on the health sector in India. She has a PhD in economics from the University of Maryland, USA, and has been working extensively in the area of health economics and policy, including demand for health and healthcare, health insurance and financing, poverty and health, costing and cost effectiveness, the economics of disease, and international agreements. Over to you, ma'am.
Thank you very much. And thank you for inviting me here. And thank you, Dr. Vijay Singh, for an excellent introduction. And Dr. Panagaria as well, because I think I can really cut short my, my talk, because most of what I wanted to say has been said. I have a few slides. These are not, these are just talking points. So I'll just share my screen. Shall I do that?
Yes, ma'am.
Thank you. What I thought I would do today is basically share my thoughts with you. These are things that all of you, because I'm speaking to a very, it's an audience that already knows what's going on in the health sector. So these are not students. So I'm just sharing my own perspective on what has happened. So I have put on these nice charts only because I like them to kind of bring home the point that India is still, it is ramping up its tests, but it's still not doing that great if you compare it to countries that have seen serious COVID cases and impact. So these are, there's a database called Our World in Data. Many of you are aware of that. And it's everything that you ever want to know about COVID. So it's kind of nice to select countries and plot these. So I was just looking at how India compares. Even with us ramping up, we are doing not that well if you look at population, tests per 1,000 people. So another one that says pretty much the same thing is over time. And we again see that while we are inching towards a better scenario vis-a-vis tests, it's really not reaching the levels that other countries like UK, Italy, South Korea, Germany, which is not here, have done. So what is the point? The point is that clearly we don't know, and Dr. Panagaria very, put this point very well. We really don't know what is the size of infected population in the country, not at least yet. Now, we can't depend on serendipity alone. We can't just hope for death rates to be low and sit back and say, look, it didn't really affect us because look, our death rates are very low, and they are very low. I mean, I had another nice graph, which I didn't put in there, and death rates have been quite low, and hopefully it is because of many reasons. It could be BCG, it could be just that our immunity levels are high, it could be malaria drugs, whatever it is. But fact is now the country we have woken up to the fact that we have to start ramping up our tests. So tests have increased in many states. Delhi has increased its test as well. And with increasing tests, we see increasing number of cases being detected. Now, also around the country, you see very recently, Maharashtra is obviously seeing the worst scenario is in Maharashtra, but Bihar, Odisha, and other states that are seeing an backward influx of migrants are also seeing an increase in cases. Now, the interesting point is that, and the sad point is that so far it was more in the urban areas, but with the return migrants going to their own origins, we would see might see an explosion of cases in rural areas, and some of that is coming in through news and other snippets that we see. One point that I want to emphasize here is that, unlike the kind of charts that I showed you, we really don't have a good database quite yet. NDTV has its own database on state infections, etc., and the number of cases. But I have been looking at the ministry and ICMR sites. I mean, there are some very aggregate numbers, but you don't really see those trends and you can't really plot all that. But the fact of the matter is that anecdotally, we have seen that cases are increasing in the states. Now, I also read there was an interview by a medical professional from Maharashtra who said that they have to now think of how to rethink on what to do about demand on hospital beds, because hospital beds are now falling short of what they need. And given that more patients will come in the near future, clearly the demand for hospital beds would increase. Both the speakers before me have said, Dr. Singh also said this, that we have a huge shortage of beds, personnel, medical supplies. We have a shortage of disposables, consumables, you name it, and we have a shortage. Even infrastructure. Rural health report, if you look at that, you get all these numbers. We also know that our medical devices sector is dependent mainly on imports. About 70 to 75% of total demand is met through imports. But we, at the same time, we also export some of it. So there are different markets, obviously. But our needs, we are mostly dependent on imports. And you wonder why India can't produce its own. Now it is ramping up, but why we couldn't have produced our own PPEs and the rest of it, and oxygen cylinders and ventilators, etc. So that is an area which needs really looking into. So we do need additional beds, we need additional hospitals, and I'm going to show you some statistics from the countries that have been worse hit with COVID. And if you look at China, Spain, Italy, France, Germany, UK, South Korea, these are some of the countries that are in the top list of in the topmost slots of worst hit countries. You can immediately see that India has all the indicators of health system indicators like physicians, nurses, hospital beds, they're really, really low. And these are facts that all of you know. The fact of the matter is I've put the government health spending on the right side on the last column, only to drive home the point that these are countries that are spending an immense amount of their GDP on the health sector. But these are also countries that have seen a lot of deaths. So we have been patting ourselves on the back saying that, oh, look, despite all these adverse indicators of health systems, we have done something great so that, we don't see deaths being that high. And I think this is just pure luck so far and nothing else. And there is another point about the numbers that I want to drive at. Now, these are some of the statistics from rural health statistics, that whole compendium that the ministry brings out, CBHI brings out. And you can see the shortages, and you can see the shortages in EAG and non-EAG states. And the EAG states, the empowered action group states, as you know, are Bihar, the usual Bihar, UP, Rajasthan, Odisha, etc. And these are also states that are seeing return migrants. So please keep that in your mind, that these are also states that are really doing very poorly in required manpower. They're falling short. This chart is on total required manpower in place, in position. So the shortfalls are very clear at PHC, CHC, and others. And these are some numbers for pharmacists, lab technicians, radiographers. Many of these people you have needed also during COVID, and we continue to need them. So they are not there. They're missing in many states like UP and Bihar in massive numbers. And if you read the full report, you'll see how poorly we are doing. Now, given that this is a scenario on infrastructure, And if cases increase, as I said, we can't depend on good luck. Suppose cases increase, and they are increasing. If it explodes in the rural areas as well, there will clearly be a pressure on hospital and hospital beds and services of healthcare professionals, right? So more doctors will have to be taken out of non-COVID related services to COVID services. So how will this whole thing play out? Now, what is going to really happen is that it is likely to squeeze out other non-COVID care. It may already be doing so. We don't have statistics right now, and we'll not have it till like the next year, and only then also only if we do a survey. So I don't know whether we will do that. I mean, NSS has already happened, so it's not likely to happen anytime soon. But the fact is that it's most likely squeezing out non-COVID care. Because of the fact that infrastructure and providers are now in scarce supply for non-COVID care, and also because we're sitting at home. So people are not being able to get to hospitals and facilities. Now, this will impact most on the 60+ population. Now, while COVID in other countries has impacted on the elderly population, in India, we hear that it's not been like that. It's much more evenly distributed across groups. But what it is going to happen, what it is going to result in is that the 60+ population that's looking to seek care for other illnesses might see a squeezing out of care. I'm going to put a chart to show you that. Now, the other thing that might happen is that people who wanted to go to government facilities, because the government facilities have been the designated facilities in the beginning for COVID care, they might now seek private care. And private care at all kinds of private facilities, we are not sure of the dubious of the quality. And that may result in an increased out-of-pocket expenditure on and also catastrophic illnesses. Catastrophic expenditure and impoverishment. Now, if you see something that Dr. Panagaria was saying, I really, it resonated with me. What do people go to hospitals for, and what kind of ailments are they all reporting? Even now in rural areas, infections continue to be the bulk of the ailments. And so it is in urban areas, but look at the infections part, it's a big chunk. Now, infections, of course, include everything. So we can't say that, oh, it's all, but the fact of the matter is that India, with this packed population and the way we negotiate public spaces and the way we are, it is going to happen that infections of all kinds will be all over the place. So clearly, if there are migrants going back to rural areas, we can be sure that COVID is also going to spread, because it is infectious and highly infectious at that. So this chart just tells us that we should be really careful, because there is a tendency in India to have more infectious diseases still, despite the fact that non-communicable diseases are increasing over the years. Now, coming back to the elderly population. Now, this is from the National Sample Survey. Most of what I've just presented 17 and 18. So the survey asks a question: what is the percentage of people who reported an illness, or who said that they were ailing in a 15-day period, and it's also there for 365 days for hospitalization. So overall, 7.5% reported being ill, but of that, the majority of those ill belong to 60+, 70+, and 80+. So these are the demographic angle that the Prime Minister was talking about. To me, plays out in this way, that most of the elderly people are ill, more than others in the population. So 32 and 36% are large numbers, more than 1/3 of our elderly people are sick. And as far as hospitalization is concerned, for the general population, it's about 3% in the last NSS, but it's much higher for 60+, 70+, and 80+. What does it say? So if it had been a normal year without COVID, you would have seen something like this happen for all illnesses and hospitalization. Now, the question arises, how many of these would also have COVID? Fair enough. but not all of them would have had COVID, right? So there would be some overlap between COVID patients and non-COVID patients in these numbers, but the rest of them would be ailing from all kinds of illnesses, non-communicable and communicable. And we can actually cut the data. I mean, I didn't have the time, but I can actually see what illnesses these people suffer from. And so we can be sure that a certain percentage will definitely be non-COVID people who would be foregoing care during the COVID period because of shutdown, lockdown, as well as squeezing out and over pressure, huge pressure on public facilities and maybe some of the high-end private facilities as well. Now, this is from NSS. It shows the percentage of people that actually access government hospitals in hospitalization cases, and while in some states it's pretty high, in many states like Uttar Pradesh, etc., the share of government hospital in hospitalization is very low. So people are actually going to private hospitals, and we know that. We've known that the out-of-pocket is very high because government facilities are not up to the mark. People end up going to private facilities. So during COVID time, you wonder what must be happening to people who, even the low percentage who wanted to go to government facilities. Are they being able to go, and how are they foregoing care? So this is one important point I wanted to flag. Coming back to why did we have to scamper around for all kinds of devices, even things like gloves, sanitizer, oxygen cylinders, etc. I think the main reason is, as we have said over and over again, is that we have not prioritized health. If you look at the government health expenditure as a percentage of GDP, it's pretty much has remained the same over the last 20 years, give and take a few percentage points. So we have been spending around 1 to 1.3 to 1.2, whatever it is, you take your pick, it is the same. There is a sameness to our prioritization of health sector. Now, if you look at the next one, what does the Ministry of Health spend as a share of total government expenditure? That has also been very little. This is the last one is budget estimate, but the blue bars are actually actual government expenditures. And you can see that the Ministry of Health as a share of total government health expenditure is also minuscule. So government is prioritizing other sectors and not quite prioritizing health, which is, again, something that you've known. And look at this, these allocations in the current budget. So you see that health gets about 2.2. Of course, defense is always 10.6, etc. And even education is marginally better than health. But health has, even in the last budget, health has not been prioritized. And you wonder how, with this kind of low level of spending, actually you don't wonder. I mean, have we been prepared? We have not been prepared because this is what we do. If you look at trends in center state share, you know that the states are more. I mean, 63% is coming from states. That is where we needed to beef up the finances. States should get more finances in their hands to deal with COVID, clearly, because they are it is a health subject and they are dealing with primary care as well as all kinds of care at their level. So have we done that? Have we transferred money to the states? I mean, we hear every day that states are asking for more funds. That is legitimately theirs, share of GST, etc. That has also not happened. However, what has happened is there has been certainly some huge allocations in the last 1 month or so in various lots. And even today, I think the finance minister said something. But the fact of the matter is that hitherto health has not been prioritized and there is an urgent need to do so. There is a thing called epidemic preparedness. I was looking at WHO and they have a whole list of things that one can do. India has not been prepared for epidemics. And that is, why is that? That is very strange because there have been epidemics elsewhere. Ebola has happened in Africa, there's SARS, etc., H1N1. Every time there is a lesson to ramp up health spending, but we haven't done so. So clearly there is something that has not happened, and this is not this government, that government. Over the years, that has been the case. Now, we also know that there's huge need to increase expenditure for COVID, which is happening. There's been cuts in various ministries are taking cuts in their budget allocations. There's severe recessionary trend in the economy. We may be seeing negative rate of growth, which is going to impact on government revenue, certainly. Now, if it does happen like that, can we be sure that the government allocations to health would increase? How can we be sure? So whatever we are spending now may just revert back to business as usual next year or even less, unless something amazing happens in between now and the next fiscal. I don't see that this may be a temporary trend of investment. It cannot be sustained because we're in a recession. And the question is that we won't have data now, but clearly some sectors have been impacted due to squeezing of funds. Can we be sure? Because some people are saying, oh, immunization has been impacted, etc. So which are the areas that have seen squeezing out of current allocations and seeing kind of a fall in investment? My major question is about PMJ. Now, we have done some work for the Finance Commission. They asked us to do so and come up with cost and finances of the PMJ, and that it is going to be hugely expensive if PMJ is going to be successful. Now, what do we mean by that? I mean that if PMJ is to cover the entire 40% that is supposed to cover, then the expenditure that the government is going to incur is going to be huge. The only way they can keep the expenditures down is by not covering most of the people they're supposed to be covering. Now, whatever is, be that as it may, the point I'm saying, the limited point is how will PMJ continue without adequate funding? What about health and wellness centers, which has anyways not seen a huge investment if you look at per health and wellness center costs and expenditure? So will that affect the HWC move? And what about private care? Now, if in fact during COVID, private care is going to increase because of various reasons, accessibility. So if you are in a lockdown and if you have to go to a doctor, you wouldn't go to the farthest doctor because you'll be seen, you'll be caught, there'll be cops, etc. You may just go around the corner and see another private physician who's sitting in the house next to yours. So if that kind of private care is going to increase, it may in fact revert us back to a higher share of private public in our total expenditure. And that we can only say with time. And what about the health systems in these EHS states? I've already talked about that. I'm really, really nervous about if COVID breaks out in rural areas of Bihar and UP and Rajasthan and Madhya Pradesh, etc. I shudder to think what might happen if there is a huge outbreak, because the health systems are not up to the mark in these things. So I just want to stop here and just say that these are things that you already know, but my concern has been the missed treatment-seeking behavior, the elderly, impact on the elderly, impact on people in the lower quintiles, out-of-pocket expenditure being higher, etc. So the last point I want to make is, which is my, something that I always think in the context of all the announcements that we keep hearing, is that the states are where the actions are. I mean, I think that this is like Dr. Panagaria was also mentioning that there was delay, etc. All of that, and also what we really don't hear from the government is how are the states going to deal with COVID if they're not given higher allocations. Now, I'm not sure that all these announcements that have been coming, and a lot of people think it's only liquidity, it's not really stimulus, etc. All that, I am not getting into all that discussion. But what we really don't see is one sentence saying that, hey, Kerala, take this money and do the best you can, or West Bengal, do the best you can. That's really not happening, and they all need those funds. So if every day we delay transferring funds to states to deal with their health sector, and states are cash strapped. They've always, if you look at the state health finances, the picture is no different from the centrals. It's really almost static. The way their health financing has not grown is very serious. So let me stop there. I'll be happy to take questions later on. Thank you.
Thank you, ma'am, for your insights on the health sector. Now we'll be moving on to the education sector. We have Professor Abhirup Mukhopadhyay, who's a professor of economics at the Economics and Planning Unit, Indian Statistical Institute, Delhi. He's an alumnus of Delhi School of Economics and the Pennsylvania State University, and was awarded with the Mahalanobis Memorial Medal 2018 by the Indian Econometric Society for Quantitative Research. He has worked extensively in the field of education in developing countries, especially India, public policy issues, in particular the NREGS, development economics, labor and health issues using econometric methods. Over to you, sir.
Hi, thank you, Yash. So let me start by just thanking the Rajasthan Economic Association, the TIES, Professor Vijay Singh, for inviting me for this. I will just try to open my slides, and all right. So let me begin by saying that one of the ways we can look at this whole issue is that this is a country that hasn't invested enough in human capital, health, education. Probably education has been slightly better than health, but both have been fairly poor in terms of what the government has invested. There are long-standing issues that Professor Singh, for example, talked about: quality of education and other issues in education, in higher education, about higher education being in perpetual crisis. What I want to do is I want to get away from that construct, because to be honest, I don't think we can move much forward. I don't think society is going to radically change its ways of how it allocates money to at least education. Health may be slightly different because it's a health crisis. So the way I like to think about it is that there will be issues that come up because of the crisis and how deep the crisis will be, which will affect the amount of money that can be spent on things which are health and education. But COVID brings also a particular kind of issues which I think will come up in the short run, right? And Professor Singh has already alluded to some of them in terms of online teaching and what will we do, how will we have exams, and so on and so forth. So while to some extent it may sound a little bit that I'm going to be focusing on almost kind of mundane administrative issues, I think these are going to be the extra challenges that we have to face with in coming in the next 1.5 years, I think. So I want to talk about them rather than talk about the fact that what should be done to change Indian education levels and so on and so forth. Now, my lens is going to be fairly limited because I was asked to speak on higher education, and while I thought that I should maybe speak on education per se, I think this is such a huge thing that maybe it's good to speak on only one aspect of it. So let's get started. So what I'm going to do is I'm going to tether what I say to some data, okay? And I'm going to suggest some things, particular interventions or ways of thinking about these problems, which are going to be tethered to data. Okay. Now, we can argue about the methods, about the practicality, and so on and so forth. And I look forward to your comments on that in the discussion. Okay. So the main issues I'm going to be thinking about, right, in this particular 15 minutes I have, is the issue of pedagogy. So basically, how do we teach? And we know that for teaching, a bunch of things are important. We know that there will be a requirement for social distancing, till at least a vaccine or a large-scale vaccination program comes in, which is very far away. And then, of course, there will be pressure on education institutions to adopt some sort of an online teaching. So I'll talk a little bit about that, and I'll respond to Professor Singh's, with numbers in terms of access. Then I want to talk about something which is not exactly higher education, but remember, one objective of our higher education is in some sense to produce students who will pretty much hit the labor market, right? So we are looking at people who are going to be in undergraduate or postgraduate degrees, and they will join the labor force. And there will be, there might be concerns that we are going to be facing, high level of unemployment because of particular sectors not working, which will then start putting pressure on, people asking, these students are coming out of these institutes, we're not getting jobs. So, education institution is not nowadays, not just about education, it's also about, employability of people. And of course, no one observes employability. People typically tend to observe whether someone is employed or not. So we must think about, what this particular crisis would mean for the link between higher education and the kind of jobs people might get or not get because of the crisis. Okay, so so I just want to make one disclaimer here. To be honest, everything I'm going to be saying here is speculative, right? As you know, we have very little idea about the future path of infections. It may go worse, it may become better, and even if it goes in a particular direction, I'm going to be talking about things which may or may not make sense to you, but I mean, will be largely partial equilibrium kind of thought, that what happens if we do one small thing, we try to change one small thing here and there. But of course, this is not even an India shock, this is a global shock, right? So for example, as Yash pointed out that, we may have more students if this crisis goes on and people may not go outside. But you can think of this, that if students are going outside the country or other states, then it's basically relative, whether you are safer relative to somewhere else. So it's not just your problem, it's also everyone else's problem relative to yours, which will determine. And since we don't know these things, a lot of things what I will say will be speculative in nature. So just take it for the argument made and not necessarily that I'm giving you some, silver bullet or some gospel truth. Okay. So in terms of pedagogy, COVID-19 is presenting and will present to all education institutions, including universities and colleges. So it's not going to be specific to universities and colleges, but since we are talking about higher education, let me talk about them. A challenge to teach, right? And one of the challenges is that we know infections are known to increase in crowded places. So we know that even after all the lockdowns shuts down and we go out, there will be spurts of infection, and they will be highly correlated to the density of congregations, right? And colleges and universities have at least two focal points for being flashpoints. Classrooms, hostels, to being two of the most obvious ones. Of course, if you have gone to college, you might even say canteens and so on and so forth, but those are things you can have legislation on, but at the very least, you must have a classroom, and you will have to, in some sense, think about the students who live in hostels. So I'm going to talk about these two aspects of the problem. But before I talk about the specific problems, let's try to think about the quantum that we have to deal with, right? So, in the latest data that we have on students, we have 37.4 million students in higher education, right? I'm going to talk about Rajasthan also, since I'm speaking, to many people through the Rajasthan Economic Association. I thought I should bring out some numbers for Rajasthan too. It's about 2 million students studying in Rajasthan at various levels of higher education. And of course, not every household who lives in Rajasthan has students studying in Rajasthan. So if I think about households, then about 2.5 million students have households residing in Rajasthan, right? Now, why do I point these two out separately? I point these two things out separately because you can see that the first, Rajasthan point, about 2.08 million students studying in Rajasthan, is a problem for institutions in Rajasthan, right? Those giving education, right? Now, all these students may not be people who live in Rajasthan, but many of them will be people who come from outside, but the institute has to deal with that. In contrast, the second point is the point about, these are Rajasthani children, right? So they study in Rajasthan, but they also study in other places. So as a state, if you have to think about about higher education from a welfare angle, in terms of, it's, people who are residents of Rajasthan, you have to think about that population, right? So there are two things that we might want to think about, so if you are a Rajasthan government, you may want to think about what are institutions going to do, and then what it's going to do for households which have children who are in higher education. Okay. Now, the education of this population, if social distance requirement is something that we insist on, is going to be tough, right? And of course, one of the ways and means to minimize contact is going to be online teaching. I'm going to talk about online teaching, but I'm also going to talk about the fact that you will need a mix of some things to be able to do so. Before I talk about that, though, I want to kind of set aside this question on hostels, right? Because we know that, residential dorms, hostels are actually a place where traditionally infections increase at a very fast rate. So what's the quantum in India that live in actually student hostels? So it's about 1 million, so 11 lakh students who live in student hostels. That represents a fairly small, about 4% of students or higher education students. About a quarter of these students are out of state, right? So you can see immediately that it's not, if you are thinking about a state policy, it's difficult to think about one state, right? Because in some sense, we have a lot of people, a lot of students that are traveling between states. So a concerted policy, while this is a state subject, it may be advantageous to think of this at the pan-India level. And I'll come to that at a later point, right? So of course, one of the requirements that you immediately do is you may need to move to a lighter hostel arrangement. Perhaps can accommodate, so with social distancing norms, you can perhaps accommodate only half of the students in the hostel. And so one must focus on non-residential requirement. Now, so let's give an example of Rajasthan to make this point, my next point, clearer. So here's the institute perspective. So for example, in Rajasthan, about 1.8% of the students who study in Rajasthan live in student hostels, right? And about 10 to 11% of them are from out of state, right? So this is the quantum of people who live in hostels in Rajasthan, okay? So for what we need to do perhaps is to need to move a large chunk of them to non-hostel arrangements. So, it is true that there is a fair proportion of students who in fact stay out of the hostel. They stay with, PGs, they stay with in houses, which are less hostel-like. And so as a practical measure, it may be possible or it may be desirable to move students, not all of them, but in some sense allocate some of them, at least half of them outside to decongest student hostels. So one happy fact, for example, for Rajasthan is that 94% of students who study in Rajasthan study from home. And as I said, residual stay in other arrangements. So, that's a good thing. So we don't have to worry so much about hostels, but to the extent that there are 37,000 students, 38,000 students in hostels, there has to be a way to reallocate them or to move some of them to this other arrangements category, right? And so these issues are, this is just an illustration with Rajasthan, but these issues are similar numbers you get for India too, and something that I think one has to think about. In terms of now the household perspective, right? So think about, Rajasthani households. So we have 55,000 students, Rajasthani students who live in hostels, right? 40% of these students live in hostels out of the state. Now, this is not the responsibility of institutes in Rajasthan. However, Rajasthan government, insofar it cares about Rajasthani households, should do something about it, because the welfare of Rajasthani households is in some sense, a responsibility of the government. So there are implications to think about. And now I point out that, while institutions will think about their problems, government also needs to get involved in this issue, because it's not an issue of one state. It's a pan-India issue with people moving and staying within different states. Okay, so with that, so I would consider that to be a relatively smaller point and probably a slightly easier point to deal with. So I started with that. Now let's think about online teaching. Okay. Now let's think about the institute perspective. So I'm thinking about this from the side of the institutes in Rajasthan. So one way to hold classrooms is through online teaching. But what are the numbers on this, right? So, Professor Singh alluded to the fact that, will we be able to do it? Let me give you some facts. So it seems that only 52% of students in higher education, so I'm only focusing on higher education right now, only 52% of this very selected group of students who are in higher education have in fact household internet facility. And when I say that, it includes smartphones. So, many people may feel that, interventions and innovations over time have increased in net connectivity. Geo has increased net connectivity, but this is 2017-18 survey of the NSS, which is post Geo. And it's only that 52% of students have in fact household internet connection, right? Now, if you're studying the sciences or programming, only 28% of students have a computer. Okay, so these are two big facts which, as again pointed out by Professor Singh, these are going to hit you in the face as an administrator, how to hold classes. Now, there is some better news if you are thinking about urban institutes. Urban institutes have students who have slightly better internet connectivity and a slightly better computer connectivity. I point out computers separately from internet because if you're doing some of the sciences and engineering and programming, you need a computer. You can't do it from a smartphone. As it turns out, there is a fair degree of heterogeneity. Rajasthan is in fact slightly better, both in overall usage. Among urban children in higher education, 71% have internet, right? So that's not a bad number. 71% is, I think, a number that one can live with, right? When we're thinking about online teaching through maybe smartphones or internet. So that's for some states like Rajasthan, and I'm pointing on some states because then there are other states like Bihar where this would be a crazy policy. Some states, and there are many like this, with 70 to 75% internet access, it may be feasible, at least in urban areas, to impart education through online teaching, right? However, of course, what would the 25% do? You can't tell them to go ahead and, that we are not going to teach you. So if COVID infection is protracted, then a class, and this is an idea I put forth, a class may be needed to be divided into two groups, an in-class group and a digital class group, right? So obviously the students who don't have internet access would have to be in the in-class group, but this would be a much smaller lot. Then we have to deal with 25% students. And a digital class with students rotated, right? So that no student gets advanced. So those who have digital access, 75%, they basically log in through their internet accounts, right? And their bandwidth issues, we can come to that when we have a discussion. For the in-class students, we can rotate them, right? So we can reduce the number further so that no student gets an advantage. So it's not the case that there's a particular number of students who always come to class, they're only getting the class. So one can kind of cycle students and rotate them. So a bit like Delhi's odd and even kind of rule. So we can try to figure out that we can have a certain section of students, so a smaller set that is in class, right? And for these people who don't have digital access, we can either have all of them or have some lot of them. In fact, even between digital class, if we can accommodate enough in the class with enough space, we may be able to get people who are sometimes going on digital class and sometimes coming in class, where this order is basically changed so that no one student gets a big advantage. It's an idea. Of course, once you start moving the online teaching way, content delivery has to change, right? So, right now while we have many universities of semesters, we are far too lumpy to be able to do online teaching. So one may need to be more modular within a course. So with frequent evaluations, to avoid high-stake exams. I think having high-stake exams in this particular environment where people, are struggling to connect and come and so on and so forth is going to be very problematic. So what I think is, for sure there needs to be physical exams, but physical exams of the nature where you are, getting smaller sets of students in, so larger number of exams so that once students miss out a particular module, you can correct that, right? So you don't wait for a semester to get over or for a year to get over before realizing that you lost the person completely, right? So the thinking has to be modular even within a course. I think to some extent, some of the teaching is already modular, but it has to be probably more. And of course, within a class slot that one person is teaching has to be more modular. So which means that each class time has to be kind of divided into particular modules where you essentially teach, and then you make students ask questions. When bandwidth connectivity is low, you can send videos and then spend time in discussion with students for that particular module. And you move on when modules are the students have some degree of comfort with the module. So, we have to realize this is a different kind of medium. Students are under tremendous stress. They haven't studied this way ever in their life. So it has to be a gradual approach. And IIT Bombay, for example, has been trying some of these models. And there are institutes that are trying to innovate with this. And, I think the general education system has to engage with some of these ideas. Now, if we come to that's the institute perspective. Now, again, we come to the household perspective. About 57% of households in Rajasthan have internet access. Households, as in households of students in higher education have access. And again, 73% in urban areas have access. So urban households have access to an extent. Poorer households may need a transfer to buy phones, at least to be able to get some internet access. So one way is that, we completely get these people on phones. But as you can see, it's going to cost 215 crores just in Rajasthan to finance, at smartphones at 2,000 rupees to do this. So maybe this idea of 50-50, where you have, rotation between in-class and digital, may reduce the requirement to do this buying. And then that may be fiscally possible to do, that you buy a smaller set, people who you think cannot come to class at all, right? And you can play around with that. And that would be a lesser number. So I think that to say that it is not possible, I think that moving forward, it will be difficult to say that, right? And so we will have to think around these kind of things. So one way to think about it is that, if you start doing these randomized, where you shuffle down in sort of these odd even kind of spirit way, then you are going to basically, you can do it at a lesser cost. Okay, that's one pedagogy that I want to talk about. The second thing quickly I want to talk about is I want to talk about what happens to the not employability, but to the employment of our higher educated graduates, right? And of course, one of the concerns that we have to think about is that they are going to be affected in the labor market. But of course, that depends on what they currently do. So let's just think about what do these people do currently that is going to get affected. So I plot here in a pie chart the percentage of the labor force aged 21 to 30. So I'm looking at very recent youth, right, and what they do. And this is among the higher educated students. So you can see that one of the sectors that is largely affected, these are the large categories. And you can see that retail, people who are in retail and trade, and I think that will be affected. And it's going to be something that requires a pickup through other policies. But notice that the biggest pink part is actually education, right? So large proportion, 17% of students in higher education are in fact, employed in the sector of education, right? In Rajasthan, in fact, the number is even larger. 20% of people who are higher educated among the youth are in fact in the education sector, right? So what usually when I hear people talking about the labor market, people are talking about manufacturing, people are talking about the transport sector, people are talking about accommodation, like Rajasthan is a big tourist state, and issues like that. And they will be important for the labor force in total. However, if you're looking at what higher educated people, which is people with tertiary education, do, these are not the sectors that one would say that would have the biggest impact. Okay, so paradoxically, or perhaps not if you already knew something about labor markets, one of the hits that can come on tertiary educated graduates will come from the education sector itself, because that's where they work, right? So in some sense, it's interesting that then keeping the education institutions working and operational and hiring is important both for education, of course, to educate the population, as well as for the educated in the labor force, right? So it's interesting. So, and what aspect would that be? So if you think about where these people work, so about 13% work in school education and about 2.4% work in higher education. In Rajasthan, in fact, a large proportion of people who are higher educated work in schools, right? It's a very small proportion working in higher education. So now you can see that the feedback loop, that while we care about higher education and the employment of higher educated people that we produce in institutes, in fact, that would require us to think about school education and keeping these schools working and functional, right? Now, one argument is that, well, we know that there are large proportions of government schools. So, in some way, through fiscally, we are able to handle and keep paying wages to government schools, so they will keep operationally working in some way. But notice that 41% of students study in private and private aided institutions. In just private aided, unaided institutions, 27% of our students work, study, right? So there's a large component of private unaided education that happens in our country, and a fall in supply of demand of private sector education, which is essentially driven by incomes or other aspects which COVID brings, will have its own domino effect on demand for teachers, and therefore things like the job market for the educated, right? And so that's my last point, that we need to think in some sense about the whole education system when we just want to think about the higher education system. Thank you very much.
Thank you, sir. Thank you for your insights on the higher education. I think we don't have much time as of now, but then still we'll take up some of the questions which has been asked by the participants. One goes like this. Actually, many of them have been saying that the government's program of self-reliance, or the Atmanirbhar, as one of the important pillars of demography. And health and education both, I think, are very much pertinent to this area of demography. So the question is, during the pandemic, there has been a great deal of imagination in dispensing and stretching the limits to cover as many people as possible, more than before. Does this give you a hope that India can deliver quality healthcare for all? And what range would be sufficient as a percentage of GDP? I think Dr. Pangadia and Professor Gupta can take it up. We can start with Dr. Pangadia, sir. Sorry, are you able to hear me?
Yeah.
Yes, sir. So you can just, yeah.
Okay. Well, actually, we are at the moment acting in an emergency environment, and we have a tendency to do or deliver the best whenever the need arises. So whether it will sustain is a difficult thing to say, but only increasing the GDP, of course, would help a great deal, but it is not really sufficient, because you need quality education, quality supply of medical graduates, and quality supply of paramedics as well. And there needs to be a system where the primary, secondary, and tertiary care needs to be integrated. So far, we have actually delivered more on the tertiary care, and whatever little out of pocket expenses we have been able to reduce is good public sector hospitals. Now, at the time when the medical colleges are growing, actually there would be, apart from the increased outflow from the government, you would need public-private partnerships at the district level, and you would need an integrated, actually, residential area systems at the CSC level, so that everyone resides there and forms a first referral unit which is connected to the medical college. So the policy also needs to change, apart from just giving the grants. I hand over to Professor Gupta.
Thank you, sir. Professor Gupta, you can just take it over from now.
Have gone to universal health coverage, or they have universal health coverage, which is basically giving comprehensive healthcare to all. 4, 5, I mean, some countries have as much as 8 or 9%. So even if we can't do that much, I think 5% of GDP on health sector is absolutely minimum. The one issue is that if you add up all that the government is currently investing, because it's very difficult to add all this up, because we really don't know how much the government is spending on healthcare right now with COVID. But suppose it adds up to about 2.5% of our GDP. There are two questions. Is this sufficient? My answer is no. It's
I think there has been some internet. Yeah.
So it is not. To me, it seems that if you needed to deal with COVID by spending, let's say, another 1.5%, then that is your emergency preparedness. So you have done that investment, but now you have to take care of your primary, secondary, tertiary care. You should, and your PMJ and your health and wellness center and everything else, and your medical education, because all that comes from the same health budget. So I think that you really need to ramp it up to 4 to 5% of GDP, but that's my guess.
Right. Thank you, ma'am. There is another question. There is a possibility of the decline in the national and international out-migration of the students for higher education for few years. So do you think that our education sector will be able to deliver quality education due to this sudden spurt, especially in the wake of the demography being considered as the important pillar? Professor Singh and Professor Biru can take it up.
Yeah, yes, sir. This is not a new thing. We are saying this for quality education for a long time. And remember, quality education cannot be developed or provided overnight. You need to create this infrastructure from school to colleges to universities. So education cannot be reformed, or quality education cannot be provided overnight. So we cannot say that in a period of crisis we will provide this year or next year or next year. So we have to think in those terms separately. And second part is whether students are going abroad or not. That is a different issue. That can be a short-term break situation. They might be going for not 6 months, because foreign university has the system they can join in the month of January also when situation improves. So this COVID is not going to stop foreign going students permanently. And again, what I suggest is that we have to think in a system which provides quality education to masses also. They are to be incorporated in the system. Here we have a clear demarcation amongst the education institutions.
Thank you, sir. Yeah. Yes, sir.
Yeah, can you hear me? So, I think that this is less of a problem. First, the proportion of people who are going outside is a minuscule proportion of the actual people who study in India. So, there may be some numbers, but this as a percentage, it's very, very small. However, you think about who their institute clientele is. I mean, in some sense, people who are going abroad, many of them would have studied, at least at the, in places. I think Delhi University has now many people who are going abroad. But largely still the clientele are people who would go otherwise to Ashoka University or something like that. And those universities, are providing quality education, have the infrastructure, and the students have the online facilities to. So I don't worry about that lot. Those are selected sample, a selected kind of students. I'm reading the chat. All these problems. So what will happen? Net connectivity. How will we do? I think these are not problems for many of them, right? Of course, there are some conceptual problems. Some people have been pointing out. How do you take theoretical exams on online forum and stuff? That will remain across all kinds of institutes. But I think that, my only point here is that, I think we need to think about them at some point, probably if the number becomes large. But I think right now we think about those who are there. And I think that there is no one solution like online or not online. I think there needs to be a mixture. In fact, there could be a mixture with video too, as some people have been pointing out, standing. But I'm a big believer that teaching requires interaction. If watching videos was enough, people would be watching videos from Harvard and MIT every day and becoming, Nobel Prize winners. Teaching, as teachers, we know we need to look at students. Students need to ask us things to move forward. And so no education system can bypass that. So there has to be an interaction base, and that we can probably try to do through online and some of them in class and so on and so forth, depending on their access. Thank you.
Right. So I think we will just conclude from here. I think thank you to all the participants and the panelists. I would just request all the panelists to just give your concluding remarks. We can just do that in 1 or 2 minutes. So starting with Vijay Singh sir, the concluding remarks. Yes, sir.
What I want to see is what Dr. Indrani has said, that we have to plan long-term public expenditure in both the sectors, health and education, and implementing authorities, that the state governments are to be strengthened. That is very important. And the second case is we have to strengthen these institutions, whether you say that students are going abroad, students are not staying in India, because there are two issues. One is the employment, and second one is the quality of education. So both issues are to be seen, not due to COVID in the short term, but a longer perspective. But the issue remains, from which sector government is going to cut that budget to increase the expenditure in higher education and health. That remains a big question. Thank you.
Thank you, sir. Dr. Pangadia?
Yeah, actually, my take is like, if you want to improvise on quality education or health systems, you need actually the experts in this area. One of the major reasons is that in last 50 years, bureaucracy and the political system has kept all the scholars and the researchers out. So these are the big stakeholders. Unless they are involved, like if you talk about Corona, there are a lot of people who come to the television sets are actually not the epidemiologists. Actually, most of the information is provided by leaders rather than epidemiologists or the experts in that area. So actually, this is the right time that unless we bring forward the talent appropriate to the area you want to organize or improve, things will continue to work the same way, because we have had enough in last 50, 60 years.
Thank you, sir. Professor Gupta?
Most of it has already been said, and I agree with Dr. Panagaria that we have to increase the health spending. There is one other area I think we need to focus on, which is the federal structure. I think we really need to rethink and reassert our federal structure and decide that that states will have to be given some autonomy in subjects like education and health. And I would like to see much more cooperation between the tiers of the government for these two sectors. And I haven't seen that much yet, but I think the COVID crisis has brought it out in the open that states really need help, and they really need to be, there should be one umbrella under which everybody should be working, certainly. But within that, there should be some, the federal structure needs to be honored.
Thank you, ma'am. Professor Mukhopadhyay?
Yeah, so I am someone who doesn't believe in this utopian world. We have been saying more expenditure on health, education, quality education, all these things for many years. The only thing that works is if there is political mileage. What I want to see is some states taking the initiative and providing quality healthcare and education in such a way, like for example, the Delhi government has done for Delhi schools, that it becomes politically, a ploy in some sense where you can win votes, right? To show that you can showcase that you can handle education and health and other things in this crisis. So unless states see this as a political opportunity, leaders will not do anything. Just asking for more will never do the trick. So I think that some states actually, who especially have some advantages in access and so on and so forth, should push and try to get some models working. And then, once voters think that's a great idea, people see that, other states will try to emulate that, the center may try to emulate that. Thank you.
Right. So thank you. I think we have reached the conclusion, and we'll now close the discussion. In the end, I would like to thank the panelists for their thought-provoking presentations and their time for this discussion. I would also like to thank all the participants on behalf of the Niti Aayog Chair, the Indian Econometric Society, and the Rajasthan Economic Association for providing this platform. And I'm also, I would like to thank our behind the curtain team, Dr. G.L. Meena, who's the Secretary of Rajasthan Economic Association, and Dr. Bula Chaudhary from REA for their support in conduction of this webinar. I'm sure a lot has been discussed over here, and many things are yet to be discussed, because this is a crisis which we have seen in our lives for the first time, and I'm sure this is a very much pertinent time that we take decisions for our futures at this point of time. So I would like to thank again to all the participants and audience, and thank you for joining in the webinar. We'll come up with the next webinar soon. Good day, everyone.
Thank you.
Thank you, everyone. Thank you.